Yeah, funded by the Navy to figure out to basically make high pressure oxygen safer in the context of military diving. And that's how I got started about 20 years ago, actually. So, one way to mitigate oxygen toxicity was with therapeutic ketosis delivered, whether that be fasting. The military did research on fasting a long time ago, and then we thought about the ketogenic diet, and then that was used for seizures. Oxygen toxicity manifests as seizures, and then as we got along in our research, sort of developed this idea of ketone supplementation as a way to quickly induce therapeutic ketosis, and then that could then, by virtue of elevating ketones and giving the brain neuroprotection, prevent seizures. And everything that I just mentioned there can also be employed for cancer therapy. So fasting, ketogenic diets, and exogenous ketones, and hyperbaric oxygen. I was studying it for military operations, but just serendipitously, I put in a brain cancer cell line and saw that I saw two things. I saw that hyperbaric oxygen was killing the cancer cells much faster than the normal healthy cells, which were relatively unharmed at the level of oxygen we were giving it. And when I tried to grow the brain cancer cell lines in the presence of ketones at just 2 millimolar of beta hydroxybutyrate, they stopped growing. And I thought something was wrong with our cell line. At the time, I didn't know much about cancer, but I was just experimenting with different cell lines. And then as I dug into the research, I realized that this was not an artifact. It was something real that I was seeing, that the ketones were reducing cancer cell growth, and other experiments were showing that hyperbaric oxygen was an oxidative stress trigger that was essentially killing the cancer cells faster than normal healthy cells. So a level of oxygen that was toxic to cancer cells was relatively non-toxic to healthy primary neurons that we were studying. I think in the United States, there might be 14 FDA approved applications. So diabetic foot wounds are a big one. Carbon monoxide poisoning, decompression sickness were a few that you did mention, but you touched on like car accidents would be like crush injury, and then you mentioned radiation. So specifically radiation necrosis associated with radiotherapy in cancer. You get necrotic tissue at the site, so it helps the body and enhances. It's interesting that hyperbaric oxygen enhances tissue regeneration and blood vessel growth and different growth factors in the context of healthy cells, but it tends to impair growth and the growth of cancer cells. So and it does that. We could talk about the reasons why it does that. But I think it's, to answer your question, hyperbaric oxygen is therapeutic because it's doing it's pleiotropic, which means that oxygen is a drug at higher concentrations. And when we're breathing at room air, even if we are in a room with 100% oxygen, right? So air is like 20 to 21% oxygen, 20.6. That saturates hemoglobin, a molecule that carries oxygen in our blood. So if we increase the concentration of oxygen from 20% to 100%, hemoglobin is pretty much saturated. That's the oxygen carrying molecule. So you can't push more oxygen onto hemoglobin. But what hyperbaric oxygen does is that it dissolves the oxygen into the plasma. It dissolves the oxygen into the non-hemoglobin compartment of the blood. And then that allows the oxygen carrying capacity of the plasma, allows the oxygen to then permeate into the tumor tissue in ways that hemoglobin carried oxygen can't get to, because the red blood cells sometimes get stopped by the erratic blood vessels and tumors and things like that. But if you hyperoxygenate the plasma, that has a much greater oxygen carrying capacity, and then you can get super physiological levels of oxygen. And tumors are typically hypoxic. So when you reverse tumor hypoxia and hyperoxygenate it, what it does is it causes a burst of oxygen-free radicals. Much like radiation therapy, the efficacy of radiation therapy is proportional to the oxygen concentration of the tumor. And since tumors are hypoxic, radiation therapy tends not to work very well. But if you hyperoxygenate the tumor with hyperbaric oxygen, it tends to work in the similar way as radiation therapy in that it's an oxidative stress. That is, the tumor is selectively vulnerable to the oxidative stress from hyperbaric oxygen relative to the healthy tissue surrounding it. And we can get into the reasons biochemically why that's happening. It has to do with a porphyrin overdrive system where you get more heme. You have, you're reversing tumor hypoxia. The mitochondria are defective. So when you push oxygen through the electron transport chain, it produces proportionally more reactive oxygen species. So that's just three, but there's like a dozen or more different reasons why it's an oxidative stress trigger. And I became increasingly interested in getting away from neuroscience and other things that I was studying and putting time, energy, and resources into investigating hyperbaric oxygen and also coupling it with therapeutic ketosis delivered as an engineered diet, and also exogenous ketone supplementation could be combined together. And then a whole toolbox of metabolic drugs could be added onto that. So that started about 14 years ago, and we've been researching it ever since. We have data in our lab to suggest, and this was, I did think about this long and hard, and there was a logistical component too to doing it 3 days per week, Monday, Wednesday, Friday. It just fit into the 5-day week. But the data that I was familiar with at the time, and I guess maybe I guess I started about 16 years ago looking into this, and then we started actively researching it about 14 or 15 years ago. The protocol that we chose to do was 3 days per week with 48 hours in between hyperbaric oxygen, because that's when endogenous antioxidant systems that would elevate superoxide dismutase and glutathione would be sufficiently upregulated to protect the healthy cells from the hyperbaric oxygen, from the consecutive hyperbaric oxygen. I think in older individuals or individuals that are compromised, that you could build up oxidative stress over time, and that may be the situation that you're feeling, kind of wiped out. So there's different like oxidative stress markers that could be relative indicators of this. Of course, like C-reactive protein or high sensitivity CRP could be one. If you see that creeping up, that could be an indicator that you're building up excessive oxidative stress, and that could be problematic. So I think the 3-day-a-week protocol could mitigate some of that. And then you have oxidative stress markers like malondialdehyde, also MDA, F2 isoprostanes. There's, you could look at glutathione levels, your GSH to G SSG ratio, so the reduced to oxidized ratio. So there's different like tests for that. But I think the simple test to do could be, there's home kits for C-reactive protein or HSCRP. And then, it's usually like at least in the States, like a $25 lab test that you could do. And maybe that could be an indicator that, I think patients that are older and patients that may be undergoing chemotherapy could be vulnerable to oxidative toxicity independent of CNS oxygen toxicity and pulmonary oxygen toxicity, which could manifest too, but I'm talking about systemic increase in oxidative stress that could impact systemic inflammation. And that could be detected with CRP or HSCRP. And that could be, one way to titrate the low. Hyperbaric oxygen clinics are not even really thinking about what I'm talking about. But it's just basics. It makes the theoretical framework is such that this is something that should be done. And I think maybe more out of the box thinkers maybe do this already. And there may be tests that I don't even know about, but I'm just, thinking as a scientist, these are the basic tests that would tell you if you're getting excess oxidative stress. And that's why we chose a more conservative frequency protocol, 3 days per week. But we did feel that based on some preliminary work that a higher oxygen concentration or partial pressure was needed to really diffuse more oxygen into the plasma to really hit that tumor as hard as possible within the limitations of what's allowed with hyperbaric oxygen, which is, the upper limit is 3 atmospheres ATA, which is, most clinics don't do that. They might go to 5, 2.5 or 2.6. Some will go to 3. And then I think you had mentioned some air breaks too, which can be helpful. So for your air breaks, do they decrease the partial pressure, or they just flush out 100% oxygen and then you just breathe air at hyperbaric pressure, right?
Yeah.
Well, there has not been, of course, the randomized controlled trials to really dictate. And then I think there's a lot of heterogeneity in people's types of cancer. And if you have a brain cancer, you are more susceptible to CNS oxygen toxicity seizures. So you would want to start maybe at like 1.2 for only 30 minutes or 60 minutes and then adjust from there, right? And then if you've had a seizure because of a brain tumor, then that could be a non-starter perhaps, or you want to go about it very slow. Of course, the whole idea that got me into this was when you're in a state of ketosis, that's suppressing the seizures. So being in a state of therapeutic ketosis makes hyperbaric oxygen much more safer because it has a profound anti-seizure effect. Probably more so, I think even the general neurology community would say therapeutic ketosis with a ketogenic diet or fasting is probably more powerful than any anti-epileptic drug. So in that way, that could give you more, increase the margins, the safety margins, and make it possible to do higher amounts theoretically of hyperbaric oxygen therapy that could theoretically go beyond the guidelines. And I was thinking that this could be super important even before thinking about cancer in the context of carbon monoxide poisoning, where time is of the essence, and the higher the concentration will lead to a greater potential for that patient with carbon monoxide poisoning to survive. So if you could put someone with carbon monoxide poisoning in 5 atmospheres of oxygen and get that carbon monoxide off of the hemoglobin molecule by using double the amount of oxygen, and then you're protecting, against seizures. So the same thing, could potentially be applied in the context of cancer. So I am not advocating that. I don't even think the chambers go beyond, 3, but theoretically, the powerful anti-seizure effects of therapeutic ketosis delivered with a diet, and even further augmented with exogenous ketone therapy, could theoretically allow that to happen. And of course, we would need to do clinical trials and things we've done the animal model studies to show that you get an over 500% increase in the amount of time that an animal can withstand 5 atmospheres of oxygen relative to not being in ketosis, right? But we use a very powerful, specific kind of ketone ester to do that. So earlier work was done with prolonged fasting in rodents from 24 to 36 hours. That would be like a human fasting for 5 to 7 days. And there was a 250% increase, but we saw like a 500% increase, with certain types of ketogenic compounds, for example. So, so what we would like to do is ultimately develop a personalized hyperbaric oxygen protocol that you could tailor to the patient based upon specific oxidative stress biomarkers. And the same would apply to the ketone metabolic therapy, which would be like a personalized diet that is supplemented with specific types of fatty acids and exogenous ketones. And that would get you to a glucose ketone index of 1 to 2, which would be therapeutic, especially when you're entering the chamber. I think would be very therapeutic and also increase the safety of the therapy. So The dose of hyperbaric oxygen will be like, the level of oxygen, the barometric pressure times the amount of time that you're in there times the frequency, right? So that gives you the dose. So you could theoretically adjust, reduce the level of oxygen partial pressure and increase the time or increase the frequency. So we've thought about this a lot, but we have not done the dose response studies to see what would be optimal. But we just, I just read as much literature as I could on what was done, and then we went with a particular protocol that made sense from a biochemistry standpoint, from a physics standpoint, and from the body's ability to recover standpoint, and even from a logistical standpoint, right? So instead of 5 days per week having to go to the clinic every day, 3 days per week, and then getting that break day. And I do think allowing the body to recover from that oxidative stress hit a good 48 hours before hitting it again. Sometimes the relative changes in the oxidative stress pulse is a good thing. Instead of, it gives the body a time to adapt, but it's also a bigger oxidative stress hit to the cancer in theory. But we haven't done like the comprehensive studies, and it could vary depending upon the type of tumor, depending upon the patient's physiological adaptation and response. So there's a lot of things that we don't know, and we're breaking into new territory. So that's why, we need to get as much information from patients that are doing this, and ideally be measuring, biomarkers and doing like case series, and, would be super helpful. But over the years, I followed patients doing this, and there's no doubt in my mind that it's augmenting ketone metabolic therapy. And then the add-on to different drugs is also like a whole nother level, of therapeutic benefit that you can derive from it.
Like,
Well, I think there's the GKI is one biomarker, actually comprised of two biomarkers, your glucose and your ketones, right? And I think there's a lot of stress and fixation on that number, and I think it is an important biomarker, especially like in the context of like brain cancer, which we've studied it because that can also control the seizures, right? And if you jump up to a GKI of 25, that could, and you're managing seizures with that approach, that could. But with seizures, then you get a very acute and visual acknowledgement of being out of the GKI. So with cancer, it's not as obvious, right? So I think there's a lot of different tools, but I think most importantly, central to all this is a well-formulated ketogenic diet that's sufficient in protein to prevent, if you're underweight, to prevent the further loss of muscle mass, skeletal muscle mass, and then coupling the diet that has sufficient protein with some type of resistance training is going to be super important, because exercise is a very powerful therapy for cancer. Muscle is just having muscle and just staying active. It's your metabolic sink, for glucose too. But also important is, insulin levels, things that I've already mentioned, like HSCRP is an important biomarker. I had a whole list of, different biomarkers that I think are important. But vitamin B12 is super important too. Like things like getting, that status, which can drop in some patients. Triglycerides, making sure that some people get on a ketogenic diet and they're not metabolizing fat well, their triglycerides could be elevated, and that elevation of fat circulating in the blood could be contributing to the expanding biomass of the tumor, which sucks up the fat from the blood. And and then of course there's a lot of literature out there saying that there's fat fueled cancer, and then people will ask questions about, well, if that's the case, then a ketogenic diet could be feeding cancer. Some cancer cells do grow off fat, but generally speaking, and my case was this, my triglycerides dropped in half. So paradoxically, when you go on a ketogenic diet, even if it inadvertently often leads to caloric restriction to some degree, but levels of triglycerides will drop typically, so that maybe is not much of a concern. And then ketones will be elevated. So these are important. Like inflammatory markers are super important. I think it's also important to look at your hormone levels are going to be important. Thyroid, testosterone levels, estrogen levels, things like that. And if something's way off, then that could be impacting your metabolic health, which could be impacting these other biomarkers. So just like general blood work, like I do a super comprehensive, at least once a year, sometimes like twice, occasionally even 3 times a year, very comprehensive metabolic panel, CBC, and then look at like hormones and stuff too. Like a suite of things, I think it's going to be important. And then having, maybe in the case of cancer, doing body composition analysis, that could be like an in-body device that could be like $25-$30 at a local gym. Or if you want to spend the money, and here in the United States, I think I just got a DEXA scan for like $70, $75. So that gives you a very detailed information on your body composition and, your bone mineral density and skeletal muscle mass. And I think it's extremely important to maintain, to even try to improve your body composition while you're doing. That's going to be a really important factor to prevent the loss of skeletal muscle mass, which correlates with cancer cachexia in patients that have it. So I think it's really important to track these things because for a number of different reasons, it motivates the patient to improve it, but it provides that incentive really to make the adjustments that are critical to not go down that slippery slope of losing that muscle mass, which correlates to function. Well, it depends. Like if you have a patient with that's has a high BMI, for example, and has a lot of body fat to lose, you could be you don't have to be as liberal with the protein. So you could, your protein could be 1 gram per, you guys do kilogram. So 1 gram per kilogram would be plenty enough. But if the patient is if the person has a lower BMI, like 22, 24, you want to, I don't see any reason to go above 2 grams per kilogram, even with someone that has a fast metabolism, is exceptionally lean, and is working out. So that would be the upper max, and somewhere in the middle, about 1.5 grams per kilogram. It sounds like a lot, but that's about, relative to ketogenic diet ratios, that's quite a bit. But in the context of cancer, I am of the opinion that, protein really is important. And I think it's important to spread that protein out over 3 meals. You could do 2 meals with like maybe a small snack or something like that. But there's a lot of cancer patients that are trying to get all that in 1 meal. And I do not think that is optimizing protein metabolism and muscle protein synthesis. I think the data would indicate that to optimize that, and you could still do time restricted feeding. For example, your first meal could be 2:00, and then, dinner at 5:00, and then, an evening snack or something like that. Like you could spread it out in that way and still adhere to a time restricted feeding protocol. But I think, anywhere between 3 to 4 meals per day would really optimize, especially if a patient is losing weight and losing muscle mass. It's really important. Central. And then get your protein optimized, and then and ideally sources like beef, eggs, chicken, fish. Fish has omega-3 fatty acids, which are anti-catabolic, and centralize that first, and then fill in the calories with healthy fats, which could be anything but, trans fats and seed oil kind of fats, right? Like saturated fats, fine. Monounsaturated fats are probably optimal. Foods rich in omega-3 fatty acids are great. And then MCTs, right? So MCTs, medium chain triglycerides, are saturated fats, and they can derived from different sources, coconut, palm kernel. And then that could be, you could make salad dressings out of that. You can incorporate MCTs when you cook. You can mix it in with foods. You could put it on vegetables and things like that. Or you could do like an MCT powder too. That could be, if you don't tolerate the oil, would be good. And then for carbohydrates, you want to keep that to a minimum. But I do think that adding some fibrous vegetables can be beneficial for most patients. But I'm also of the opinion that a pure carnivore ketogenic diet is also therapeutic, and I've seen evidence of that in quite a few people over the years. And I've visited, for example, Paleomedicina in Budapest, Hungary, and I saw their data, and kind of case reports and things like that. And I have enough feedback from people that follow this kind of diet, and they do really well on it. So you could do everything from not a vegan ketogenic diet would be hard, but you could adhere to a ketogenic diet that's fairly rich in plants, fibrous, green vegetables and things like that, and gravitate all the way to the spectrum of a pure carnivore ketogenic diet, and which I think could be helpful to hit the glucose ketone index if the levels of meat are fatty and things like that, level of fat in the meat and oily fish, fatty fish, and things like that. And it might be hard for patients to get in the amount of calories that they need for that too. So that's why I always advise patients to work with a registered dietitian, because they not only know the science, but there's, I think more importantly, the art, the art of like working with a patient, finding their food preferences and developing a meal plan that they'll stick with. Is important, and having a registered dietitian that really understands the importance of protein and getting that protein in, and then coupling that with exercise. So it could be walking, it could be any form of exercise is going to help. Resistance exercise obviously is going to be the most bang for your buck. But to work with a registered dietitian, I think is going to be really important. And there's a lot of great books out there. Miriam Kalamian has a great book. And as does Naisha Winters, and there's quite a few books out there that and that the book could be give you the underlying principles, but I think it's really important to even do at least 2 to 3 to 4 weeks with a skilled dietitian to help construct the diet plan, and then maybe you can tweak on your own as you go. Yeah, so you want to hit a calorie level that correlates to your body's basal metabolic needs. So say 2,000 calories, you're going to need quite a bit of fat, like at least 200 grams of fat. So you have to go into this knowing, you're going to have to get, depending on your size, 150 to like, if you're a large person, up to, 300 grams of fat a day, if you're very active and large, for example. So, and that can come from a variety of different sources, everything from, MCT is a good filler, but also MCT oil, if you titrate it in, it's hard for patients to put on weight with MCT oil because it doesn't really get stored as fat. It gets oxidized real quick, but it is a source of calories and can make the other calories you're consuming, for example, the protein, be used more efficiently for protein synthesis to get those caloric calories as energy in. It could help divert that protein, if that makes sense, to doing what it's supposed to do, like be the building blocks of the body, right? Whereas it's kind of sparing the protein, if you will. Similar to just, if you add carbohydrates in, carbohydrates are protein sparing. Fats, in the context of a therapeutic ketogenic diet, are protein sparing.
Would that reduce gluconeogenesis of the protein then, if you're consuming MCT?
Yeah.
So that would help lower your glucose too.
Yeah, definitely. And so just getting the fats in through fatty cuts of meat, so fatty protein, and that could be, for me, I haven't eaten, this is like sardines in olive oil, right? So it's like sardines in extra virgin olive oil. So you're talking, this has upwards of 25 grams of fat and 20 grams of protein, just about 20 grams of protein. So there's, sources of that are already packaged for you that have the macronutrients listed, or you can just go buy eggs are a great source. We live on a farm, so we have a freezer full of, grass-fed beef and things like that are good. If make friends with your local butcher, go to really encourage people to kind of buy locally too. That's where you're getting like food that's fresh. Avoid ultra processed foods by all means. And there are, some other things that you can consider. Convenience foods like nuts can be great. Some people don't process nuts really well, and some people can have nut allergies. But like if you're going with nuts, macadamia nuts are probably the most ketogenic that you would go. Cashews are a little bit, can be higher in carbohydrates, and especially for people that are trying to keep weight on. Nuts and nut butters can be really helpful for people. Conversely, for most people using a ketogenic diet are trying to lose weight. So, and when I hear what they're eating and they say they're not losing weight on a ketogenic diet, and they tell me, they're eating nuts, if they could cut back on the nuts and dairy, in some cases they may need to completely eliminate them. Then I could see typically like people start losing weight really fast on a ketogenic diet. So, but in your case, and for cancer patients that are trying to maintain their weight and gain weight, nuts can be irritating to the GI tract. So one thing to consider is nut butters. So nuts have a lot of insoluble fiber. For me, like if I go over 100 grams of nuts per day, it just does not agree with my GI tract. Whereas nut butters are much more GI friendly for me. So it's something to consider. Well, I have a lot of experience with this because I've been researching ketones for cancer before anyone even heard about. I don't think exogenous ketones did not even exist when we were doing research on this. I do have some really what I think are important opinions on this. And we've published on this, and people could look at the literature, like what we've published. There seems to be a benefit, I would say, to using, for everyday use, racemic exogenous ketone salts. So specifically, Audacious Nutrition makes Keto Start, and that is a product. Need to disclose that it's not my product, but my wife does have a company, Audacious Nutrition. And essentially that company was started because she's also a neuroscientist and researcher and done work with cancer. She wanted to develop a product that mimicked what we actually did in the lab, like the ketones that we use in the lab. So that product is beta hydroxybutyrate salts, sodium and calcium salt, but it's D and the L. And you're going to see on the market soon a whole kind of marketing campaign around the L beta hydroxybutyrate, which is the other enantiomer. So that tends to, don't need to get too into it, but you have two forms of beta hydroxybutyrate that are mirror images, D and the L. And if you consume it, the D gets burned as fuel pretty quick, and the L gets metabolized about 2 to 3, maybe even 4 times slower. So it stays in circulation, but it has really important signaling effects like anti-inflammatory effects, epigenetic effects. And then part of it converts, maybe 20% or more converts slowly back into D. So, and maybe the listeners don't need to really know all that, but just know that the D and the L, and that's a racemic beta, it's more like a drug form of ketone therapy that I think could be beneficial. And we've also demonstrated in the lab that specific DL beta hydroxybutyrate had the anti-cancer effects. So now I don't know if the D alone has pro-cancer effects. I don't think it does, but the DL seems to have effects at reducing proliferation and increasing cancer cell death. So now you might not want to use the DL if you are doing, the Tour de France. You might want to use like a pure D formulation, although there's not evidence to show that that's superior to the DL. But I think in the context of cancer, I think you want to use racemic DL beta hydroxybutyrate or racemic 1,3-butane-diol, which I don't even know if they sell that outside of a research chemical. And it tastes really bad, and it also is a little bit hard on the liver. So this is something that I've experimented with quite extensively, consuming this. So I would gravitate towards the ketone salts, specifically the Keto Start by Audacious Nutrition. Should still be on Amazon. Go to the website directly. Sure, yeah, and it's Keto Start, all one word, Audacious Nutrition, and I'll send you the link to that, the direct link to the website. I think the person who's buying from Canada may have to pay customs, though. There might be like a customs fee, or maybe that's included, or some kind of discount there. But I know they're pretty much sold all over. But that's what I use personally. I tolerate very well 2 packets a day. That's 20 grams of beta hydroxybutyrate. So that will lower your glucose and it will elevate your ketones. And someone even following a low carb, non-ketogenic diet could achieve and maintain a glucose ketone index if they're using Keto Start, for example. So that's can be very beneficial. So ketones, they may have an appetite suppressing effect. So what I recommend is like eating a meal and then drinking the exogenous ketones after the meal. And that will lower the elevation of glucose from the meal. And then your body will actually, probably absorb the ketones better if you take it with a meal too. So it has like this benefit that, it can reduce the potential negative impact, metabolic impact of the meal, which means, it'll prevent the GKI from going up if you take the Keto Start with a meal. No, it doesn't taste like salt. It actually tastes really good. So you don't even have to worry about the taste. Like it's something that the Keto Start product is actually something that you will look forward to drinking. And it's got a short, unlike a lot of supplements out there, it's got a short ingredient list. So it's like 10 grams of DL beta hydroxybutyrate, and it's got some sodium, calcium, magnesium, and potassium. So it's got all your electrolytes. And then it has the sweetener is monk fruit. It has like a pinch of monk fruit, but monk fruit's very sweet. So it has, and that basically blocks the taste of the beta hydroxybutyrate. So it is quite sweet for me. But a lot of people like to take a half of a packet because it has double or triple the amount of ketones as other products. So some people will take 1 packet and that'll be their whole day supply, and they'll divide that packet into 3 servings, right? So I usually take a half a packet. Like if I'm really like hiking or really doing something demanding, I'll consume a whole packet. But typically like a packet's almost like 2 doses in 1 packet. So that's just the way they decide to dose it, just to have a much larger dose than normal dosing. Good question. We're doing research on that now at Duke, but in the context of oxygen toxicity, and we're using a ketone ester now. What we did in the past, we haven't published it yet, is the subjects would follow like a modified ketogenic diet and then take the ketone salts with a ketogenic diet that has MCT. So continue to do the diet, continue to use MCT, and then prior to hyperbaric oxygen, you could do a dose of the Keto Start, and that would lower glucose, elevate ketones. It would also produce, some people get like symptoms of hypoglycemia in the chamber, which is quite common. And elevating your ketones with Keto Start would prevent signs of hypoglycemia inside the chamber. So that's an extra benefit. And in theory, it makes hyperbaric oxygen safer. It has a vasodilating effect, so it could actually enhance the blood flow to the tumor and actually help to improve hyperoxygenation of the tumor. So in that way, it's also racemic in a way that it doesn't have like an overwhelming antioxidant effect, because like it's kind of redox balanced. I don't want to get into like the whole redox effect of the ketones, but I think there's definitely advantages to a racemic compound for cancer for different reasons. And then the racemic compounds also tend to lower blood glucose more than the non-racemic. So you get the elevation, of the ketones, but you get the lowering of the glucose as well. the low glucose is like it's you're enhancing, your healthy tissue is enhancing metabolic uptake of glucose, so it's stimulating metabolism, right? The ketones would probably lower glucose a little bit more, but you would be asymptomatic for hypoglycemia because the ketones would be giving your brain an alternative form of energy. So, the historic studies by George Cahill and Oliver Owen at Harvard Medical School, where they inject insulin in subjects that were fasted for like 40 days, and they drop the glucose down to like 20 milligrams per deciliter. And they were asymptomatic for hypoglycemia because their ketones were elevated. So this way you can, I guess you could use the term artificial ketosis. So you're artificially elevating your ketones with something that's bioavailable. We do have the D and the L in our bodies, just the L is much lower levels naturally. So you're elevating your ketone levels up, and then that would, in theory, augment the cancer-killing effects of hyperbaric oxygen and also protect you from having symptomatic hypoglycemia just by giving, ketones as an alternative fuel. I think whatever's comfortably achievable for the patient, right? So if you take a patient that has type 2 diabetes and their normal glucose is like 150, and then you drop it to 100, they could have symptomatic hypoglycemia, right? So if the patient, assuming the patient has like a normal glucose, I think it would be safe to go down to 60 milligrams per deciliter if their ketones are elevated into that 1, 2, and even 3 millimolar range. So they would most likely, if their ketones are elevated at 2 millimolar, even, they're going to be asymptomatic for hypoglycemia. I think most normal healthy people, of course, like if you have an infection, if you have a disease process, that could change the scenario. So that's important to understand. I think it's really important for people to get electrolytes, to stay hydrated, because those things could increase the chances for ketoacidosis. There are also certain drugs that could increase the chances for ketoacidosis because they could inhibit insulin production or insulin sensitivity. So this needs to be acknowledged, and that's why monitoring is really important, to just for the patient to understand how they feel at certain glucose levels, so they could more or less self-diagnose themselves, and also be transparent with their healthcare practitioner, with the hyperbaric tech that's on hand, to say, hey, I'm going to measure my glucose and ketones here. Okay, it's low, but this is normal for me, so you don't need to worry. My ketones are going to be elevated. Maybe explain the concept that, if ketones are elevated, it could look like I'm hypoglycemic, but the ketones are giving my brain another source of energy, so don't worry. So this is a common scenario that I get. Even doctors and hyperbaric technicians will reach out. I have this patient, and he's like, their glucose is 50, and this is, they've read what you're doing, and I was like, well, do they have signs of hypoglycemia? And I was like, no, they're perfectly fine. And I was like, well, that should be first and foremost important. So what's normal for one patient may not be normal. So 50 going down to 60 could be severely hypoglycemic for the patient whose normal glucose is like 120, 130. So that relative change is what's important. Yeah, with those drugs in the context of hyperbaric oxygen therapy, I would experiment with them significantly and have experience with them outside of the context of hyperbaric oxygen therapy, because that could change metabolic physiology in a way that's kind of unpredictable, right? So that needs to be taken into context. With an SGLT2 inhibitor, I actually had to change my lectures to the medical students, because there's like a new term that would be euglycemic diabetic ketoacidosis, right? So they're, especially in the context of a ketogenic diet, what has been observed, at least in some case series, and has been reported, maybe even for like those trying to manage their type 2 diabetes, for example, with the ketogenic diet, is that some of them may have normal glycemia, but have essentially diabetic ketoacidosis, so like runaway ketosis, right? And it's normal glycemia because they're using an SGLT2 inhibitor, right? And so the thing is that it's going to be really important for patients using these drugs to use them to start at the lowest dose possible, assess the side effects, and then adjust the dose very incrementally, from there. Because an SGLT2 inhibitor is more risky with a therapeutic ketogenic diet because your glucose is already pretty low, and further lowering it, especially if your ketones are not elevated. In theory, if your ketones are elevated, there's some protection there. But there have been some people that have side effects with those drugs. Now, metformin's pretty well tolerated. It's very, everything I'm talking about is dose dependent. So you might want to start off with 500 milligrams with meals, once a day, and then go to like 500 milligrams, twice a day. Most people that go above 2,000 milligrams per day start to get some GI side effects, some loose stools and things like that. But so assess your tolerance to metformin. And I do think, I've had a student did his whole PhD dissertation research on metformin. I think it's a helpful drug as a standalone therapy. It's useful maybe for cancer prevention in the context of type 2 diabetes. I think pancreatic cancer is less. You knock down your risk, if you're managing something like type 2 diabetes. And I think it could potentially synergize well with a ketogenic diet. And it is a weak mitochondrial poison too. Actually, like our research showed that it elevates superoxide. So in theory, if one was to take it prior to hyperbaric oxygen therapy, that it could potentially enhance the oxidative stress killing effects of hyperbaric oxygen therapy.
Is that a good thing or a bad thing? Enhance the oxidative stress?
Yeah, it could enhance the cancer killing effects of hyperbaric oxygen therapy. Yeah. So I would just be very cautious, using it, because there's a potential for things like, lactic acidosis and things like that. So I think lower is better for the dose on that. Sometimes these things, when we start doing polypharmacy, especially with an SGLT2 inhibitor and metformin and ketogenic diet and exogenous ketones, I just described, 4 things that are a pretty big hammer at knocking down glucose, which is, in the context of cancer can be great, but I think you just need to, that's why we really need to develop a framework, and we need to really educate practitioners on how to do this from a personalized standpoint too. And that's why, wearing something like a continuous glucose monitor, like this is the Abbott Freestyle Libre, and I have, boxes of Dexcoms behind me too. I think a Dexcom is approved for hyperbaric oxygen therapy, and I think maybe the Abbott Libre 3 is. You might have to fact check that, but I think the Dexcom, I think the G6 and G7 are approved can be used with hyperbaric oxygen. At least I think we have subjects in our research protocol we're doing now at Duke that have them. So those technologies can provide good guardrails and really a safety net for patients experimenting with these. I'm a big advocate for continuous glucose monitors, especially in the context of what we're talking about here. Well, we have an informational website, which is ketonutrition.org. Keto Nutrition, all one word, .org. I don't sell any products or anything on there. It's just information, right? So our blog probably has a dozen or more articles on cancer. So I would check out those blogs. I think we do have a page like products that we recommend, and there might be some products there, some monitoring devices and foods and ketone supplements and stuff like that. My wife has the company Audacious Nutrition, and Keto Start has that formulation of ketones that we use in our research. I'm a host for Metabolic Health Summit, and the Metabolic Link podcast, which we've had a number of people on that talk about, therapeutic ketogenic diets in the context of cancer. So check out the Metabolic Link podcast, the ketonutrition.org, and for a ketone supplement, Audacious Nutrition, Keto Start. I think it would really depend upon the type of cancer. I think that's important. The standard of care can work for a variety of different cancers, although with metastatic cancer and brain cancer, there's a far less efficacy for the standard of care. So in that context, I am of the belief that, and this is really important, that types of cancers that are relatively refractory to the standard of care can be efficacious in the context of ketone metabolic therapy, especially if it's used with hyperbaric oxygen therapy. So this is just based upon anecdotal reports and based upon the science, and maybe even I'm talking about chemo, radiation, and immune-based therapies, especially checkpoint inhibitors. Ketogenic diets can augment the adaptive immune system to make these checkpoint inhibitors work more robustly, you know. So, but the standard of care is like the thing in the toolbox that you add later if you have some time. So to quickly prevent the further growth and spread, getting into a glucose ketone index between 1 and 2, maintaining that off the shelf, if you want to call that, metabolic drugs like metformin at a low dose. Exercise is really important. Just sunlight, just wearing a continuous glucose monitor. Like, these are all things I would do right out of the gate, and then work very closely with a registered dietitian who understands the art and the science of ketone metabolic therapy for cancer. Denise Potter is great, and her team. I think she's got like 6 people working for her. I refer her quite a bit. That, and then to explore not only ketone metabolic therapy, but the hyperbaric oxygen therapy, if that's logistically possible and feasible for the patient. And then even, we didn't talk about it, but IV vitamin C is another, potential therapy that could be done ideally like on the same day as hyperbaric oxygen therapy. And then, a number of different add-on, drugs after that, that maybe when we do a part 2, we could go into, the top, 5 to 10, drugs that could augment ketone metabolic therapy. And exogenous ketones too. So really nail down the diet. That's really going to do, that's the biggest lever. And then, things like MCT oil, exogenous ketones that we mentioned. And then using a device like the Keto Mojo device, which is like the handheld meter with a continuous glucose monitor, is also very useful. So these are the things you want to do out of the gate. And and then follow the work of Dr. Thomas Seyfried. He got me into this, area of research, and do as much research as possible on this, on your specific cancer too. And then, really go on to PubMed and then even clinicaltrials.gov, and then pull the research reviews and meta-analysis for what's being done for your specific kinds of cancer, because there's new things being developed all the time that have the potential to work. And to just educate yourself as much as possible, because a lot of times doctors they do their thing, but they don't really explore cutting edge science that's above and beyond the cookie cutter protocols that they use in oncology in many cases. So